Hello, everyone. I'm Professor Subodh Dave. I'm the Dean of the Royal College of Psychiatrists, and it's my absolute pleasure to welcome you to the next edition of the Dean's Grand Rounds webinar. The topic today is really very interesting: ketamine misuse and increasing problem, consequences, and responses. As you all know, I set up the Dean's Grand Rounds a couple of years ago, and then I have to say they've grown in popularity, so much so that we've got our sessions booked out till well into 2026 summer, I think. So that's really exciting. And another special thing to share today is that you are part of a historic webinar today, because it looks like we've hit the highest number of audience today. We've crossed 1,500 people, so which is really amazing. Also means that because there are so many of you, we can't really have the chat open, but do use the Q&A box to ask questions. I don't need to remind you that please be civil and respectful and keep your questions brief. Our panelists will try and answer the questions as much as they can on while the webinar is on, but we also have a Q&A panel discussion at the end. I really wanted to thank Deepa Krishnan. You can see her on my screen. She's the lead of the Dean's Grand Rounds and is the architect of this particular endeavor at the college, which has been so successful, and also the staff team led by Catherine Ayers and a wonderful team. So thank you to all of you. And it's my pleasure to introduce Emily Finch, who's the chair of the addictions faculty, is consultant addictions psychiatrist in South London, and is my fellow trustee at the board of trustees of the Royal College of Psychiatrists, and a wise soul throughout, and I think someone I turn to time and again to get advice on. Just a couple of housekeeping rules. Today we will be recording this session. The recording will be available. Give it some time, about a week or so, it will be available. We'll also send out the certificates if you have registered, as will come to your email address. And do use the feedback link that we send you. The feedback is very important for us to know what can we do better this time, next time, and if this is to continue. So thank you all, and Emily, welcome, and I look forward to hearing from all the wonderful panelists we have today. Over to you.
Thank you very much, Subodh, and welcome to everyone who's signed in today. And I hope we're going to have a very interesting session today. Why did we decide to do a session on ketamine? I think ketamine is a very interesting substance for addiction for psychiatrists generally at the moment. As we know, there's an increasing evidence base for its use in depression. But I think at the same time, it's important that we talk about what we as addiction psychiatrists are seeing, which is really quite a significant rise in the number of people misusing it, and also our increasing knowledge of the harms that it results in. So that's what we're going to take you through this afternoon. We're going to take you through some of the patterns of use, the harms, and some of the responses that are beginning to be developed in order to treat this group of patients who present to us. I have another thing I want to mention. Many of you may know that one of our addiction psychiatry colleagues, Professor Jan Mellekar, sadly died a month ago, and he was going to be one of the people presenting on this session. His colleague Faye has taken over his topic and much of what he's going to say, but I think it's important that we all acknowledge Jan's great contribution in this area. Finally, we're going to start with hearing from somebody who has experienced many of the harms from ketamine use. His name is Saul, and he has kindly recorded a video for us to explain what his involvement has been with services and what his experiences have been. He is very kindly also on this call and is happy to take questions and to contribute to the discussion at the end. But his initial contribution is going to be a video. So I hope we can now start with that.
So good morning. Thank you to agree to be interviewed today and give your testimonial about a ketamine addiction. So I have a set of questions that I would like to ask you. So first of all, I think my first question would be how and when did you first come into contact with ketamine?
I remember I was getting ready to go to a party when I was about 14 and I met my mates up Bexley, Broadway. That was at the meeting spot where we was going to meet before we all travelled down there. And really, someone had it on them and got it out and offered me it. And I suppose at the time I was just a bit curious. I think a couple of my mates were trying drugs, smoking weed, doing ketamine, doing cocaine, and then I thought it's kind of the perfect time for me to try it really. I think kind of just experimenting as a kid as you do.
Yeah. And what was your understanding of ketamine at the time?
At the time I had none. I kind of just went into it quite open minded. When it got described to me, it got described to me as it'll make you feel drunk. Um and really I didn't really like drinking because back then it would always end up me being sick or making a fool of myself. So I thought, oh, I'll try that and maybe I can sort of see how it feels really. And so yeah, my understanding of it was kind of next to nothing. It was just kind of it got put in front of me and I tried it.
Okay. And how your ketamine use change over time? So what happened afterwards? You were quite young, 14, experimenting, which
So
is
yeah, after 14, it was just kind of after 14, I didn't really use drugs at all until I was 16 when I started going to like illegal raves and stuff like that. And then from there, kind of because I had younger brothers, my mum didn't really like drugs in the house. Like, I'd go out every Saturday, come back Sunday morning, and she didn't really know what to do with me. She didn't want drugs around my brothers as well, so she kicked me out to my dad's. And then when I got to my dad's, I had a conversation with him about like why I got kicked out. So I'd been going to raves, going to like using drugs, and like his response was, "All right, like you're just being a kid, like you're just growing up." So from there, I kind of had the green light to use whenever I wanted without like having to worry about what your parents think or anything. Like I'd kind of just had, yeah, I could just get used when I wanted, really.
yeah. And uh, was there a specific moment when you realized that your habit was becoming a bit problematic?
I think at first, I think because I was getting real, like no real consequences from it. Like I could still hold down a job. I'd use like on the weekend. It wouldn't go into the weekday, but then quite quickly it went into like Friday, Saturday, Sunday. So Friday, Saturday, Sunday, Monday, Friday, Saturday, Sunday, Monday, Tuesday, and then just progressed that way. But I think the first time the problem is when I started like to wee blood, like pass blood in my urine.
Yeah,
So that was like my kind of first this is this is a problem. And back then when that happened, I'd always used to be able to stop, and then kind of my health would get better. I'd think I was fixed, and then I'd just pick back up where I left off, really. And then it just followed that cycle for a few years. So I started getting health problems, stopped, sorted myself out, thinking I'm fixed, and then went back to it.
yeah. And how did ketamine actually affect your mental well-being and physical health afterwards when you were using more regularly?
So my mental health was terrible, really. I kind of I've looked into it since I've been sober, and I kind of see like studies like they're trying it for for depression and stuff like that. And I don't know if I was kind of trying to self-medicate how I was feeling, but really I just couldn't. My mental side, it was just kind of an easy escape for me. And as I said, with no consequences of at first I was waking up and I'd feel brand new, like I weren't having like a hangover from drinking or wasn't having to come down from cocaine or ecstasy. So it was kind of just for me at the time it was perfect, but then my physical health was terrible. Kept like ketamine became my food, so I wasn't really eating. Went down to 7 stone. Um, my I was I had no quality of life. Like I had to give up work because I had to go to the toilet every like 5 minutes to try and empty my bladder. Um, so yeah, my quality of life really was rather staying in the toilet most of the day because there was no point leaving the toilet to go to my bedroom to then go back to the toilet. So I was just in there for hours and hours. So even that on the mental side as well takes a toll. I lost most of my friends. Luckily, they're back in my life now, but it's because I put in kind of some hard work really to try and sort that out.
Okay, thank you. And okay, so if we talk about then what happened next, was there a specific moment or realization that make you thinking you have to stop using and sort it out? So yeah, when you
Yeah,
you
so
were yeah.
I kind of knew that I had like I knew I'd class myself as an addict as such, but I always knew that, but as I said, my quality of life was so poor that I kind of just went with it. Like, I just thought that's my label now, and I'll just run with it. Really, I thought it was just going to lead me to death. That's rather like overdose or end up committing suicide. But I think the turning point was one, I just didn't really want to live like that anymore. And two, I remember having a conversation with my brother, like my younger brother, and he said that like they can't really look up to me anymore. And then kind of that was like I'm supposed to be like their older brother they can depend on, and I wasn't that. So that was kind of my turning point. And then that's when I went to my GP, and then they took me to, or they like signposted me to Pier Road.
Yeah. So the next question is what yeah, and you already said what helped you starting the process of recovery.
So yeah, the first was I went to my GP. Really, the only advice they had for me was, why don't you just stop? Which was kind of hard, really. I kind of feel like if I could just stop, I wouldn't be sitting in front of you. Um, but then yeah, they sent me to Pier Road, and then which is my local like drug and alcohol service, and then yeah, they helped me started attending groups for luckily to have a group for ketamine, which is I think is quite beneficial because I think having to get up and go to the toilet all the time without being judged is quite good, really. I think like if you're sitting in a group, sometimes you miss half of it because you are having to go to the toilet. Um, so yeah, they helped. So I started going to groups there, and from there they helped me get into rehab, which I was there. I think I went there a year today last year. Yeah.
Yeah. So and how you doing now? What can you say about your recovery process?
Yeah,
What can you tell us about the benefit and of the treatment and the fact that you have worked very, very hard on yourself?
yeah. I kind of feel like for me, I was in a mind when I first went to rehab. I was in the mindset of this could be like the only opportunity I've got to like help myself. So I kind of threw myself into it from day one. Um, so like attending every groups, every extracurriculum, like anything possibly I could do to better my life than what it was because as I said I had no quality of life. And then since then, I've kind of like I've put in hard work and I've just kind of reaped the rewards really. Like at the moment I'm living in the resettlement stage of the rehab, so still got so I'm still under Kenwood and I'm like living with people that was I was at rehab with, so all like-minded people, which is good, like good to be around. And yeah, overall just my life is good. Like last week I went and climbed Mount Snowdon in Wales, and a year ago I couldn't even walk. Like I literally couldn't even walk, and yeah, I managed to do that. So like recovery's given me a lot really.
Yeah, that's beautiful,
Mm.
beautiful. Thank you so for sharing. Just to conclude, I think our 10 minutes are now gone. Um, just a brief message for the audience. That is anything you would like just to say as a conclusive message to professionals?
The professionals, I think I'm just so happy that it's kind of been brought to the forefront now and people and it's being talked about because like, a lot of people suffer in silence, and they don't know what they can do for help, or they're embarrassed of themselves. And I think just being able to have a service there that you can go and talk to is 10 times better, because like when you're in like active addiction, you're so isolated that you think that you're the only one going through this, and the reality is not. There's like thousands, millions of people out there that's going through the same. So yeah, it's just so happy that it's been brought to attention now, and people like it feels like stuff's getting done around it, which is good.
Okay. Thank you very much. I really appreciate you that you spend time to talk to us, and thank you and good luck
Thank you.
for everything.
Thank you very much, Saul. That was very moving, and I'm so pleased you've done well. I've noticed you're manfully answering the questions in the chat, so please continue. I'm sure we'd all appreciate that, and we can address some of the questions with you face to face earlier. I'd like to continue by going back to begin to talk about what we know about ketamine and perhaps answer some of the questions that are there. I'm going to hand over to my colleague Faye, who is an addiction psychiatrist from Wales, who's developed a considerable amount of expertise and understanding about ketamine use. And perhaps one thing that is worth saying is that one of the interesting things about ketamine misuse is that this has come from all over the country. As we've been discussing it as a faculty, people have popped up and said, oh yeah, we've got it, and oh, we've got a big problem here, we've got a big problem there. And I think there was a bit of time when we all thought we were on our own and that we had patches of it. And I think what's becoming increasingly clear is that it's a national problem. So I'm hand over to Faye.
Hi, thank you, Emily. Okay, so I'm a consultant addiction psychiatrist working in North Wales. Next slide, please. I'm going to try and speak to you today. Sorry, next slide from that. I'm going to try and speak to you today very quickly because it's a short time slot. Just briefly about the psychopharmacology of ketamine. I'm just going to provide you with a bit of an update on the prevalence and sort of what's going on in the UK at the moment regarding figures. And I'm going to describe some of the adverse effects of ketamine use on multi-organ systems. Next, please. So the psychopharmacology, I'm sure a lot of people will be aware, it primarily is an NMDA receptor antagonist. So it disrupts the excitatory neurotransmission, which is primarily what leads to the dissociative anesthesia, trance-like state, sedation and such that's associated with ketamine use. It also has some opiate receptor interaction. So it interacts with the mu, delta, and kappa opioid receptors, which is why it has some analgesic properties as well as the above. It has some monoaminergic effects. So it increases the synaptic levels of serotonin, dopamine, and norepinephrine, which is probably what underlies its rapid antidepressant properties. It also has some cholinergic and muscarinic effects, and also some local anesthetic properties related to the sodium channel blockade. Next. So ketamine can be given therapeutically in multiple ways. It's often given intravenously or intramuscularly. In terms of misuse, it tends to be used usually intranasally or orally, although can be used intravenously as well. Its onset of action is quite rapid. So with IV, the onset of action is usually within around 30 seconds. Intranasally, which is probably the most common route of misuse, is between 5 and 15 minutes or thereabouts. The duration of action very much depends on the dose and the route by which it's used, but around 30 minutes to 3 hours. It's primarily metabolized by the liver via the CYP450 enzymes, and it has an active metabolite, norketamine, which has a similar but less potent effect to ketamine itself. Next, please. So I suppose it's had a bit of an interesting rise, really. I mean, ketamine was first around, I suppose, on the club scene in the UK in the 1990s, but it appears to have really increased in its use, particularly over the last 10 years, but I suspect probably more recently from around COVID time and onwards. The estimated annual users are around 300,000 people in the UK between the ages of 16 to 59. However, the largest sort of age range that seems to be affected appears to be between sort of 16 and 24, with it being particularly high in males around the 20 to 24 age group. It's often used in the context of polysubstance use also. We're having a rising number of people admitted for treatment. So you can see the figures there. 3,600 people started on treatment for ketamine in 23 to 24, which was up from 9 years previously, where only 426 were reported to be accessing treatment. As mentioned, it appears to be particularly prevalent in the younger age group with some studies. This study was from 2024, which reported up to around 3.8% prevalence. And there are some quite interesting statistics which show a really marked increase in the last 10 years. Next, please. So ketamine has some acute effects, so acute ketamine toxicity. This tends to present to ED and such. People can present with impaired consciousness, agitation, hallucination, delirium, confusion, and at times tachycardia and hypertension. This sort of acute toxicity tends to be short-lived and usually resolves without much intervention within 12 hours or less. At higher doses, there can be a much more pronounced psychological effect, including very severe dissociation. You can get short and long-term memory impairment, which can be in the context of intoxication and can resolve after. It can have cardiovascular effects on tachycardia and hypertension. This tends to be more common with pre-existing comorbid health issues or in the context of polysubstance use as well. This is the same for respiratory depression, which is more common at either very high dosages or when used with things like benzodiazepines, alcohol and such. There are behavioural risks which can be associated with the acute intoxication, such as impaired coordination, accidents, disinhibition, and risky behaviour. Next, please. So the chronic effects is where I'm going to try and spend most of the time, but again, this is a bit of a whistle-stop tour. So obviously, dependency is one of the chronic effects. Using ketamine regularly can cause really severe cravings, anxiety, low mood, and this can perpetuate this sort of feeling of withdrawal and the need to continue taking it. As you start to withdraw, the anxiety can feel worse in the short term. More problems with mood, tremor, sweating. It does eventually abate, but it can take quite some time. There can be cognitive deficits following long-term use, and this can affect both long and short-term memory. There can be a lot of psychiatric effects, including emotional instability, mood swings, depersonalization and dissociation, a worsening of anxiety, a worsening of depression, which is interesting given its use for treatment. It appears to be that in treatment, the dosage, the frequency, and the control of ketamine use is quite significantly different to when sort of misused or overused. So in the therapeutic setting, we're trying to achieve a regulation of the glutamate and opioid systems. But when ketamine's misused, there tends to be a flooding of the brain with ketamine, which can lead to sort of an overstimulation of all of these symptoms, which can cause longer term changes in the neurotransmitter systems, particularly dysregulating glutamate and dopamine, which is probably what leads to that depression. There can be associated suicidal ideas. There can be hallucinations and delusions during the intoxication phase, but these can also persist and can resemble a schizophrenia-like presentation. Next. So Liver toxicity can be one of the side effects of chronic use. This is mediated via direct hepatocellular injury, and this is seen in inflammation of the liver, raised LFTs. There can be bile duct damage, inflammation, fibrosis, and strictures. There can be gastrointestinal issues. It's a little bit more difficult to understand the mechanism of these, but quite commonly people describe something called K cramps, which is some quite sort of diffuse abdominal pain, which appears to be separate to the pain associated with a bladder damage that can also be caused by ketamine. You can experience bloating, constipation, altered bowel habits, severe nausea and vomiting at times, and weight loss. As mentioned before, respiratory depression is possible if used in high doses and in the context of polysubstance use. There can be cardiovascular issues. These can either happen acutely or they can happen more chronically. People can be particularly susceptible to these if they have structural issues with the heart or electrolyte imbalances. And as mentioned above, the electrolyte imbalances can be relatively common if people are struggling with gastrointestinal symptoms. Next, please. There can be ear, nose, and throat complications if the ketamine is used intranasally. Apologies for the typo on this slide. Chronic nasal inflammation and damage can occur when the ketamine is being snorted. This can lead to rhinitis. It can lead to nosebleeds. It can eventually lead to septal perforation and nasal collapse. People can struggle with repeated infections, either in the nose itself or in the sinuses. There can be postnasal drip and sore throat. This can lead to irritation of the vocal cords and vocal changes, and at times there can even be upper airways inflammation. Next. So one of the main and probably most common issues with ketamine use is the associated bladder damage and sometimes kidney damage associated with this. So ketamine-induced cystitis, so this is where there is significant chronic inflammation which can become ulcerative in the bladder. It's extremely painful. And this sort of extreme pain can actually perpetuate the need to use ketamine itself, because it can be very, very difficult to manage this pain. It can often require quite strong analgesia. The pathological mechanism isn't exactly clear for this, but the metabolites of ketamine are directly toxic to the epithelial umbrella cells in the bladder. But there's also thought to be some neurogenic inflammation and some possible immune-mediated inflammation as well. The symptoms that individuals will usually report are increased urgency, urinary frequency, pain on passing urine, blood in the urine, and at times jelly and clot-like substances in the urine as well as I mentioned, this really significant pelvic or even loin pain. This ongoing cystitis can lead to bladder wall damage, ulceration and fibrosis. So as this goes on, the bladder becomes increasingly fibrotic and rigid, which means the bladder can no longer stretch to accommodate the urine. It can mean they've got a very, very reduced bladder capacity, incontinence, and in severe cases, the bladder can become non-functional. Next, please. So as this progressive bladder damage occurs, what happens is the urine starts to back up and is unable to sort of flow out, and this causes a pressure back up the ureters to the kidneys, which can lead to damage to the ureters itself, causing things like strictures, but it can lead to swelling and pressure on the kidney tissue. This can obviously damage the kidneys long term, causing renal impairment, and this can result in proteinuria, reduced kidney function, and progressive renal failure in extreme cases. There have been a number of studies back in around 2018-19 which show that actually the duration of ketamine use is directly linked with the onset of the symptoms. So the longer ketamine is used for, the more likely that there are to be urinary symptoms that emerge, particularly over the 24-month mark. And the rates of reporting of these symptoms are sort of anywhere between 75 to around 85% of people that are using ketamine daily for 24 months, which is extremely high. Next slide, please. So I haven't gone into treatment options around this. I just wanted to just bring some things to people's mind to be thinking about. So if you're seeing particularly younger adults, but I suppose any adults really that are presenting with, lower respiratory tract, lower urinary tract type infections, symptoms, pelvic pain, any cognitive complaints, psychosis, treatment-resistant mood symptoms, be sure to ask them about ketamine use. I think it's often quite, it's often not something that's asked during routine, conversations about mood and things. Try to establish if there are any other polydrugs that are being used alongside this, so that support can be given, and to see if there's any mental health comorbidity that needs to be addressed. Ensure that there's clear communication with primary care. I think often urinary symptoms can be misdiagnosed as repeated UTIs, and individuals can receive many doses of antibiotics, but not really have much impact on their urinary symptoms. Consider early referrals to any secondary care departments that are relevant, particularly urology, ENT, maybe gastroenterology, but also the involvement of addiction services early, because it's important to know that the main thing that can help the progression, particularly of the urinary symptoms, is supporting the service user to stop the ketamine use. It's really important to ensure there's good joint working with all relevant services, particularly young person services, school nurses, and similar. Next, please. So in summary, this was a very, very quick whistle-stop tour. We know that ketamine is an NMDA receptor antagonist. It's got therapeutic uses, but the recreational and misuse is rising significantly in the UK. Early recognition, support, and urology follow-up, as well as addiction support, are essential in helping people to recover. And that's me. Thank you very much. There's some references.
Faye. That was a great canter through the psychopharmacology and adverse effects. I would now like to hand over to another colleague, Irene Guerrini, who you've already seen interviewing Saul, and is going to talk to us about ketamine use in the community and her experience with psychiatric vulnerabilities.
Okay. Hi everyone, I'm Irene. I'm the consultant lead Islam, and I'm running a clinic in the community in Southeast London. So I'm going to present some of the data that I've collected on a retrospective group of my patients. Next slide, please. So as Faye already mentioned, we have seen a trend of rising numbers of people misusing recreationally ketamine, but also importantly, especially in the last decade, we have seen over 8 times higher attendance into structured treatment of very, very young people, very unusual, thinking about, the prevalence of 20 years ago. I've been running the service for 20 years. So what I did, in fact, notice in the last 3 years was a significant increase in numbers attending the clinic. Very young patients with severe complex needs. And I start looking at profiling them to identify which needs they have and what we can do as a service to address these needs. Okay, so next slide, please. So the first thing was to look retrospectively to cases that they presented in my clinic, and try to see what kind of problems they had, and how to set up a new intervention for them. So in terms of gender, we'd say is predominantly males with quite young age of presentation, mean age of presentation of services. But 26, I had 18 years old coming through the door, quite complex needs. If you look at, for example, the age below 25, it was about nearly, as I said, a third of them were below this age, using a quite large amount of ketamine, say to nearly 3 grams, and using a lot of other substances on top of the ketamine. With ketamine only, users were approximately 38%. Quite important number they presented with ketamine-related neuropathy and also mental health problems. But I'm going into look at more in details about this group of patients. Next slide, please. So what we did, we look at frequency of use. And so we divided the 100 cases according to if they were using less than 3 days a week, 4 to 6 days a week, or if they were daily users. So in terms of gender, in terms of mean age, they were more or less similarly. Well, it was actually quite interesting. It was the amount of ketamine they were using. So if you look at the mean ketamine dose, there was quite a significant difference between infrequent users and daily users. And also what it seems quite important is to see the prevalence of ketamine-related urinary symptoms from infrequent users, which were only 14%, roughly, to 62% in daily users, with the frequent users in between. So it seems that obviously in this kind of scenario, how is important to prevent the escalation of the problem to infrequent users to daily users. Maybe, as I said, with harm reduction intervention and motivation to change and awareness about the risk of using ketamine more regularly. Unfortunately, if you use ketamine, ketamine is quite addictive, and patients seems to develop tolerance quite quickly. So the progression from infrequent users to more frequent and daily users is quite smooth, and it can be potentially very severe in some cases, with obviously more complication, mental complication and physical complications. Next slide, please. So in terms of polysubstance use, we see cocaine, alcohol, and cannabis are the most common substances used alongside ketamine, with all the rest, obviously with the prevalence of all the rest ranging between 4% to 1%. Next slide, please. Then we look more specifically about mental health problems. In the literature, which is very little studies done specifically on that topic, but as previous studies indicate, there is a high proportion of ketamine users, chronic users, with depression and anxiety. Sometimes depressive symptoms not reaching the threshold for clinical depression, but definitely quite large numbers. Next slide, please. So again, in my sample, we divided according to frequency, and again, we see a disparity between infrequent users and frequent users. So quite significant proportion of frequent users, they do have, half of them, they have actually mental health problem. I would say this is a retrospective study, so I went through obviously the notes, the report, and everything. So this is documented mental health problems that I can see. It's not a prospective study. So at this stage, I have to say it's quite difficult to know what it comes first, because obviously chronic use of ketamine induce anxiety, induce depression. But on the other hand, we work with patients, they have a primary depression, history of traumas, as you can see in the next graph. And yeah, especially common, as I said, depression and anxiety. We got quite high proportion of deliberate self-harm, suicide attempt, history of traumas, and then other conditions that they're below the 15% prevalence. Next slide, please. Okay, if we compare statistically, we could see that between the two groups, so between the subgroup mental health versus non-mental health, there is a significant impact of the age that presented to treatment. It's quite reassuring, actually, looking at these data, that younger patients actually with mental health problem, they trust the service and they do attend a quite young, quite at a younger age for treatment, which is absolutely reassuring. We do see a trend in terms of a statistical trend in the association with frequent and daily use. And definitely there is a statistical association with the amount of ketamine use, which is equally important. Next slide, please. So in terms of what we can conclude here, summarize, so the ketamine users engaging in structured treatment are predominantly young males. More than a third are below the age of 25. And more than 2/3 are using multiple drugs and alcohol, which put them at risk of overdoses and sudden death. The infrequent users have less physical and mental comorbidities, indicating the importance of harm reduction intervention and early engagement in treatment. Ketamine users with mental health problems attend the Tier 3 services, structured services at an early age when compared to users with non-mental health comorbidities. And the ketamine dose per using session and mental health problems are significantly correlated, whilst frequency of use show only a statistical trend. This analysis obviously is limited by the retrospective nature of my data. And as I say, mental health problems in ketamine use disorder are still largely unexplored in the research field and warrant further prospective studies. Okay, thank you for the attention.
Thank you very much, Irene. I'd now like to hand over to my colleague Stephen from Manchester, who works with inpatients using ketamine, and he's going to talk about detoxification and severe dependence.
Thank you very much, Emily. So hi, my name is Dr. Stephen Kaar. I'm a consultant addiction psychiatrist at the Chapman Barker unit. And next slide, please. I'm going to be talking through our ketamine detoxification. Just a few declarations before I begin. So I'm involved in a ketamine-assisted psychotherapy for alcohol use disorder study with Professor Celia Morgan, and I also have received some funding for a GLP-1 study as well. So next slide. So I'm going to briefly introduce the CBU and inpatient detox, just because inpatient detoxification is quite a rare intervention and something that I think people should know a bit more about. Don't worry, I'll be brief, Emily. I'm going to present our ketamine detoxification data that we've collected over the last 9 years, and some of the things I'll talk about will be similar to aspects of Faye's talk and also to Irene's as well, and there's some interesting differences, I think, in the data we've got as well. So I'm going to present our trends on admission numbers. I'm going to talk about the demographics of our treatment population briefly, talk about use patterns, lower urinary tract symptoms, the kind of hepatitis picture that we see, and then briefly summarize our detox regime. Next slide. So the Chapman-Bark unit is a specialist inpatient detoxification unit. We're actually a national unit and receive referrals nationally. We're kind of at the top of the pyramid when it comes to detoxification. We're led by consultant addiction psychiatrists. We have a large MDT of physical health doctors, psychiatric trainees, RMNs, RGNs, and then the psychosocial team as well. And I think that's quite important because as Irene has already outlined, and Faye, there are quite significant harms that can come along with ketamine, and Saul too, obviously. So it's important that people do have sufficient medical knowledge and expertise to deliver these kind of interventions. So the CBU is interesting because we have our planned admissions, of which there are 26 beds, and these are how our ketamine detoxification patients come in through local drug and alcohol teams. But we also have something called the radar system, which essentially means that if you are suffering with alcohol dependence and you present to an A&E in Greater Manchester, you can be admitted to our unit 365 days a year, 24/7 to have an alcohol detox. And that was put in the recent COSUM report from the Royal College as an example of good care for people with co-occurring substance use and mental health disorders. And just to plug inpatient detoxification a little bit more, the last big review that Colin Drummond, who will be familiar to many of you, ran, suggested that we are effective and should be recommended for detoxification for severe alcohol or drug problems. And as the eagle-eyed viewers will see on the right, that's Andy Burnham, who recently helped us reopen our unit. Next slide, please. I promise I'll talk about ketamine soon. So without labouring it too much, these are all the different sorts of things we're able to do at a specialist inpatient detoxification unit. Alcohol and polysubstance detoxification is kind of our bread and butter, but we also are able to do opioid dependence, substitution therapy, stabilization. We're well managed at treating people with a history of DTs and psychosis, thinking about treating people with clozapine, changing clozapine doses, use of the Mental Capacity Act and the deprivation of liberty safeguards, and even court of protection orders more recently. We've started doing microdose induction of methadone to buprenorphine. We have our Christie's pathway, which involves people who have been recently diagnosed with cancer, who also have alcohol dependence and require a detox, coming into our unit so they can start chemotherapy or radiotherapy. Our homeless pathway, we detox special populations, such as people who are pregnant with a forensic risk, low BMI. And that's something that we found in a lot of our patients who come in for ketamine detoxification, that that ketamine tends to cause appetite suppression and people are often low weight. We do GBL and other novel psychoactive substance detoxification too, including ketamine. So now I'm going to talk about the clinical data that we've collected on ketamine detoxification. Thanks very much. Next slide. So this supports what both Faye and Irene were saying about changes in the treatment-seeking population. So this is our data going back 9 years, and you can see in between 2016 and 2020, we were doing perhaps 1 or 2 ketamine detoxifications a year. But then in the last few years, it's just rocketed. And actually 36% of our referrals or admissions came in between January and August 2025. And you don't need the statistic really to see that that is a significant increase in the last few years. So something has happened recently, and there are far more people seeking inpatient detoxification. And as I said, we take referrals from across the north of England, so it's quite a wide geographic area that's been affected. Next slide, thanks. So just to drill down a bit more on this sample, this includes 59 ketamine detox admissions. So the majority of people were using other substances as well, which I'm going to talk about too. But 23 were ketamine only, and we're going to do, we've got a bit of a subgroup analysis on that population. I guess supporting what Irene was saying, the majority are male, but we're actually seeing a lot of female admissions for ketamine detoxification as well. And more recently, there's been a fairly even gender split, which I think is novel in the substance use treatment seeking population. It does, our patients do tend to skew young, so the mean age is 25 years old. And we usually do a detoxification for ketamine over about 15 days. Most people are snorting or inhaling ketamine, and thankfully, we have about 80% of our patients who completed detoxification as well. So we actually get fairly good outcomes from detoxification from ketamine. Okay, next slide, thanks. So this is a graph that shows the mean maximum ketamine use per day in grams. And we have number of patients on the y-axis. So most commonly, people are taking between 0.5 gram to 3.5 grams a day. But then we've got some people who are using much heavier as well, up to between 18.5 to 21 grams a day. And that's in the ones that we've got recorded. So obviously there are limitations to this data set because we're relying on the clinical data. As Irene was saying, we really need some prospective studies where we're more rigorously measuring these kinds of usage data. Next slide, please. So in terms of withdrawal symptoms, again, this is a kind of frequency chart here. So you can see in terms of the top 3 most commonly reported withdrawal symptoms in our patient population, we have craving at the top, and then anxiety, and then agitation. And I think the ketamine withdrawal symptom is fairly poorly characterized at the moment, so much more work is needed there. And obviously we don't really have many medications that can effectively treat this, although I will talk about that in a minute. Next slide, thanks. So in terms of our patients who are using ketamine with other substances, again, it was quite common, and we found that people were either using plus cannabis, plus alcohol, plus cocaine, also benzos, so that supports Irene's study as well. Next slide. Now, this table is how we explored in our current preliminary analysis the relationship between lower urinary tract symptoms, of which we know is a major complication of ketamine dependence and heavy ketamine use, and raised liver transaminases. We focused on ALT, but we intend on doing a more detailed analysis of the hepatotoxic picture, because there also seems to be a cholecystatic picture as well. So if we start at the top of this table, you can see there's roughly a similar mean daily ketamine use between males and females, although the males were maybe using a little bit more. In our ketamine use alone group, there was a greater use of ketamine. You can see that the vast majority of patients did report lower urinary tract symptoms, and in that group of people, they tended to be using a higher mean daily amount of ketamine, 5.9 grams. In the ketamine only group, so the previous one was sort of ketamine plus other substances, you can see as well that the presence of lower urinary tract symptoms, of which the majority of our patients had, was associated with a higher daily use of ketamine, which supports the idea that they're dose related and related to the ketamine. And then 2, we wanted to look at ALT because we started to notice our patients, when they were admitted for ketamine detoxification and also when they were discharged, they tended to have either high ALT or their ALT rate increased massively. And ALT is obviously a measure of hepatotoxicity. It's a liver function test. So again, in the people that we had ALT recorded, that was 32 on admission and on discharge, you can see that the higher dosing appears to be associated with the raised ALT group. And we're going to do some further analysis on this statistically, but it is an early indication that there is a dose-response relationship between ketamine use and ALT, and this is supported by case reports in hepatology journals as well. Next slide, please. So we were interested in finding out whether males or females were more or less likely to have lower urinary tract symptoms, because we do know women are at a greater risk of perhaps of getting UTIs and those kinds of complications. We didn't really find a difference in gender, either in our total population or in our ketamine only group. That's probably a selection bias because, as I explained, our unit tends to take the most severe cases of ketamine dependence. So we tend to only see people whose ketamine use has got to the point of causing lower urinary tract symptoms. So I think this question we can't really answer, but needs further exploration. Okay, next slide, please. And then we wanted to see again whether there was a statistically significant difference in our ketamine-only group between ALT on admission and ALT on discharge. And you can see our mean ALT was 103 on admission, and on discharge it was 220. So it was abnormal on admission, and as a group it had gone up massively as well. And that's our t-test there that you can see. And then there was a correlation, but not significant, between mean ALT at baseline and mean ALT on discharge as well. So there's something interesting going on in the liver of people that are using ketamine. Again, it's another harm that needs further characterization. Okay, next, please. So finally, I'm just going to quickly talk through our treatment program that we offer for people coming in for inpatient ketamine detoxification. So we tend to use a diazepam reducing regime. We tend to use something like 5 milligrams 4 times a day, plus some PRN. Sometimes we need to use a little bit more than that. There are some risks of severe withdrawal symptoms and seizures, which is why we pick diazepam. We also encourage oral hydration. We monitor lower urinary tract symptoms very closely, and we do a urine dipstick on admission and after day 5 to see if there's any blood or protein or leukocytes in the urine. Often people have urinary tract infections, so we treat those as well. We monitor the U's and E's. We do see some people who are in acute and chronic renal failure. We've had a patient who had nephrostomies and actually required a dose of IV gentamicin due to the risk of infection. We monitor LFTs, as I've told you about. And then we think about how we can optimize medication to reduce the burden on the liver and the kidneys. So, because obviously if somebody's got very raised liver transaminases or acute renal failure, that can limit the medication that we can use to treat, for example, the K-clamps, the cystitis, the dysuria, which is often very, very prominent in the patients that we treat. With that in mind, we have used a range of different analgesia to treat those symptoms, because I think one of the major problems of detoxifying from ketamine is that you can experience a resumption of pain, but often because you're removing the toxic substance of ketamine, the inflammation in the bladder and the abdomen will improve anyway. So generally, the patients that we treat get much better. The hematuria, the dysuria all settles down. The frequency tends to settle down. But some of these symptoms do persist. So we use naproxen, if safe, nefapam, diclofenac, occasionally some paracetamol if we're not worried about the liver. Although again, I think the interaction between ketamine-induced liver injury and paracetamol is not really known. And we may use codeine if we really think the pain is particularly severe and those other medications are not indicated. But again, we would only use that in a time-limited fashion, and we wouldn't discharge anyone on codeine. The urologists do use other medications such as mebeverine and sulfenicin. We may consider starting these medications on the unit with advice from urology, but I think again we're really in the early stages of knowing how helpful these medications are. Some of our patients do find them helpful, but I think you've got to be really careful that you're not causing urinary retention or worsening the symptoms. And then something that we do on the unit as well is we occasionally use promazine to help agitation or those cravings or those anxiety temporarily. Again, we don't discharge people on this, or we may use promethazine as well. And as Irene alluded to, a lot of our patients do have co-occurring mental health disorders as well. So we will treat the underlying disorder through our psychosocial program, onward signposting for therapy or medication management. Next slide, please. So that's it. I just have to acknowledge Sarah Shackleton, who did an incredible job at extracting all the data and then analyzing it for this presentation. So thanks, Sarah, and also thanks to Dr. Oni, who came up with the initial analysis, and then all the staff at the CBU. And if you need us, we're on this email. That's it. Thank you very much.
Stephen, that was really interesting. Now, finally, before we have time for some questions and discussion, we've got 2 short presentations. I'm going to start with my colleague Irene, who's going to talk about developing community service, and then go over to Tracey Myton, who's going to talk about developing a different type of service in a different part of the country in Manchester.
Okay, next slide, please. Next slide, please. Okay, so the first thing we did, as I said, we did this analysis. We look at needs, And we collected some feedback for service users about the current the provision that were in offer. So service users reported that professionals do not understand ketamine addiction fully. Services are mainly tailored for Class A drug users. There was a limited intervention for young adults with ketamine addiction. They did not relate to all the Class A users, especially in group settings. As Saul said, it was one of the things we thought about and immediately. And a limited availability for inpatient detoxes and residential rehab, and also the lack of understanding of the impact of ketamine addiction by primary care professionals and A&E staff and other medical professions. Next slide, please. So we look at the to design a new pathway specific for ketamine addiction, and the main rationale for doing that was predominantly to improve the patient experience, treatment retention, avoiding early dropouts, client tailored intervention, and complex needs provision, looking at mental health and physical health provisions. Next slide, please. So the ketamine project was born. So what we start doing from the beginning was to create a rapid access to treatment for ketamine clients, because working with young people is very important to engage them as soon as they present. Otherwise, you lose the opportunity for treatment. So we established, for example, priority triage assessment for under 25. And at that stage, as soon as they are triaged, we were just doing blood tests, because as we heard from Stephen, we got a significant problem with liver conditions and obviously kidney problems and so forth. And then we were doing BBV testing straight away. I have to say that before establishing this project, we actually trained all the staff in the service to understand what ketamine addiction is and what the various presentation and risk associated to the degree of severity they might present with. Then we develop ketamine fact information sheet, harm reduction pack, including sniffing tubes, and we develop ketamine checklist for service users to look at various signs and symptoms of ketamine addiction. And we develop craving scales. Craving is a very difficult entity for ketamine users. Is the main reason for relapsing, is one of the reasons why they found it very difficult to stop. Also, we set up a specific ketamine group with weekly session based mainly on psychoeducation and MI intervention, plus also they were having one-to-one key working session. We establish obviously slot for medical assessment and mental state examinations, and in some cases, if obviously appropriate and indicated, we start prescribing off-label naltrexone as a relapse prevention and anti-craving measure. Quite difficult lately, because obviously some of the clients, they do come and to the service and they have a very, very raised liver enzymes, which it may exclude them to be prescribed naltrexone. And also we monitor closely the weight, because they tend to lose weight quite rapidly. And also we establish direct referral process to functional urology at King's. And obviously we put in place a liver scan assessment if needed. And also we have a psychologist on site, so it was easy for us to refer them for psychological session and maybe referred on to more long-term talking therapies. And also we are lucky we got good access to inpatient detox and residential rehab option. So just to conclude, next slide, please. So for me, what is important here is the fact that at the moment we haven't got the model of care for these young patients, and so which they need a specific clinical intervention, and also treatment guidelines are quite required as well. Joint working protocols and guidelines with other professionals, including urology, mental health services, pathology, primary care professionals. More study and research is needed, not only on the clinical aspect of the matter, but also looking at treatment outcomes and efficacy of what we provide, pharmacological intervention, psychosocial intervention, and so forth. And also training for A&E and GPs and other professional on ketamine-related physical condition. Like I say, bladder symptoms, acute abdominal pain, seizures, low mood, short-term memory, significant weight loss. So thank you for the attention. And thanks.
Can I hand over to Tracey, who's going to talk to us about setting up a service in a different way?
Tracey, are you able to put your camera on, please?
Sorry, I've got in a right pickle here.
No worries.
I'm not sure what's happened.
So if you just press the green button, you should be able to share some content from your PC.
Not to worry. If you would share my slides, please.
We will do. Thank you very much.
So, thanks. So I'm a community addiction psychiatrist working for a mental health trust in Greater Manchester, and I'm based in Bolton. And we're fortunate to have been able to set up good integrated care for people using ketamine in Bolton. We wanted to have quick access to urology services for ketamine users coming into treatment. And currently we can refer directly to a urologist by email. And I have a joint MDT meeting with a local urologist. So for people who might be interested in setting up such a service, I thought I'd tell you about the factors that were in place to set it up. So we were able to develop this because of a number of fortuitous factors. Next slide, please. So I think it's helpful that we're an NHS trust, because I think that makes it easier to liaise with the local acute trust. And when I started in Bolton in 2018, I was able to persuade the local acute trust to fund one session of my time. So I do one session of addiction liaison in the acute hospital each month, and I see inpatients, and I have an outpatient clinic to which, so any consultant in the hospital can refer into that if they're concerned about their patients with addictions. I also had an extremely enthusiastic ST4 doctor, Rebecca McKnight, who saw some ketamine users in clinic and began to liaise with an exceedingly obliging local urologist. And then she and an ST in urology started providing teaching to staff in A&E and to our recovery coordinators, and suggested a pathway for referrals. So our recovery coordinators are now able to take a basic urological history and to recognise ketamine neuropathy, and can refer directly to urology. And I have a joint MDT with the local urologist face to face in the outpatient department, and we see patients together, which is very helpful. And what's particularly helpful is that I've got access to the acute trust case notes, because I think I can see what's going on, and I can add the notes from our community service to the acute notes, which I think is helpful for the urologist. Next slide, please. So from my urology colleagues' perspective, I think she's functional urologists don't see young people very much, and they don't see sick young people very much. And I think she's been quite motivated to get involved with ketamine users. She's exceedingly patient when they DNA and does things like write letters to them personally, telling them about the benefits of them coming along to their outpatient appointments, which I think is quite unusual from consultants in acute trusts. And she seems to do this out of her scheduled timetable. She's understood how community addiction services work, and I think being able to explain to her the complexities of our commissioning has been really helpful. And she even became a trustee for the local young person service Early Break. And on the back of that, I was asked to speak at the British Association of Urological Surgeons conference in Manchester in March. And I think the urologists were really receptive to hearing about how we treat ketamine users. And now if you go onto their website on the homepage, they've got a link for ketamine use, which takes you onto a link for Ask Frank. So I think we're fortunate that urologists have really embraced the importance of understanding how addiction services treat ketamine use. Next slide, please. But I think, as well as good liaison with urology, we need really good PSI, because most of our patients don't have detox. We've got quite a small budget for inpatient detox and rehab. So we will be treating people mainly in the community, and we need to be encouraging them to reduce their ketamine use in the community. So because we're part of quite a big trust, we've got a big footprint, and we've got an online ketamine PSI group, which is helpful for obvious reasons. I think it's quite difficult for younger ketamine users, because often if they've come from young persons services, they're used to being one on quite a small caseload, and then they go on to a larger caseload when they're in adult services. So I think having a bespoke ketamine PSI group is really helpful. And I think they also tend not to relate to older drug and alcohol users, although they probably actually do have quite a lot in common with them. So these groups have 4 sessions and concentrate on harm reduction, discussion of urinary symptoms, mutual support and motivation. And they're not primarily to prepare people for detox, that would be separate. But I mean, we do also refer people for detox, but we try and treat as many people as possible in the community. Next slide, please. So unfortunately, to end on a more negative note, there are a lot of challenges with these liaison, with this liaison. And I think one of them is the IT system challenges. And it is very hard because of the NHS IT systems, we can't read each other's notes. And I think it would be really helpful if we were able to do so. I think the success of the services rested on the enthusiasm of individual clinicians. And the urologist that I've been talking about, she's about to retire. And I think it would be surprising if her successor is as enthusiastic. I think we need to keep repeating the teaching, because resident doctors rotate and there's a high staff turnover. And as I said, I think the transition from young person services to adult services is tricky, because often it's a new service. Unfortunately, we don't have any evidence yet. The numbers are still quite small, so we don't have any evidence yet that we're retaining people in treatment. And finally, this service isn't specifically commissioned. And actually, the cost is mostly borne by the acute trust. And I suspect they're not really aware of that. And unfortunately, to end on a disappointing note, the trust that I work for has now lost the contract for Bolton. And so from April, there won't be an NHS provider of the community addiction service there. So that will certainly mean that the liaison session's lost. And I think it will be harder for this integrated service to continue. So finally, I think we need to think about how these continuous changes make it difficult to maintain such services, and that they really ought to be specifically commissioned. Thank you.
Tracey. I think it's an interesting reminder at the end how addiction services are differently commissioned from mental health services, and this does make some of these responses quite difficult. We probably don't have time to go into it in detail today, but it doesn't make it more of a problem. Hopefully we've now got sort of 15 minutes or so for discussion. Deepa, are you going to look at the questions or shall I?
I can help you, Emily, but if you can.
Okay, that's all right.
Yeah, thank you.
I think I'll go right to the heart of it. I think Rupert put a question or put a comment really on the chat. And I wonder if he'd like to come in and talk about it, or we can comment that individuals taking ketamine for depression certainly don't seem to have these symptoms, and the case series that have been done don't seem to support very much that this is a dose-related problem, and it's to do with much higher levels of ketamine use. I wonder if Stephen, you want to come in on that, because you're obviously involved in the ketamine trial at,
no problem.
at low dose.
I mean, I agree. I think the studies that I showed actually, or the results that I showed actually suggest that this is largely a dose-related effect. And it is very, very different taking ketamine in recreational settings and taking it every day in a dependent fashion compared to having several, at most, interventional sessions with IV ketamine or S-ketamine as part of a treatment program for depression or for alcohol use disorder, where it's very clinical and controlled, and we're very careful to screen out people who may struggle with ketamine dependence and other drug issues. So yeah, this is a different population to the ones that we're seeing in treatment for depression, for sure, and a different intervention, obviously.
Irene, do you want to come in?
Yeah, I totally agree. Yeah, there is dose is very, very different, and obviously the frequency, daily uses are completely different from patient using, or patient will be prescribed. We prescribe therapeutic ketamine or S-ketamine. So I totally agree with that.
Okay.
Yeah, we'll stay with this side.
Another question someone's asked is, could somebody comment more on the use of naltrexone and acamprosate? Well, I'd probably go to Irene, but anyone else might want to comment.
Yeah, I put in the chat, actually, there's been recently published recently a small paper on naltrexone, and there is the rationale. So the naltrexone seems to be at the time, it seems to me to be a best candidate. Obviously, looking at the studies on the use of ketamine in resistant depression, naloxone, and some studies using naltrexone, they reduce the antidepressant effect. And also there is some other studies indicated that obviously the ketamine also works pretty well on the opioidogenic system. So, and obviously the craving is mainly modulated by amygdala, and so there's a long story. It's more complicated than that, but if you read the paper, my paper, there is a full story about it. So naltrexone seems to be a better candidate, and reading the research on resistant depression, the use of naltrexone in experimental studies and naloxone, he pointed out it could be a good pharmacological intervention. It doesn't work for everyone. So it does for the more complex chronic users, heavy users, is quite difficult to stop, of course, spontaneously. So there's no scope for naltrexone. So there is a window where you can probably stop the ones that progress from frequent users to more towards the daily use using naltrexone. They need to obviously stop for a few days before we can prescribe. And in more complex cases, it's been proven difficult because of the liver impairment. So it's off license, it's not licensed, but we are working on a more serious trial exploring, in a proper trial exploring the effect on naltrexone on reducing the craving, which is a complex entity as well. It's not just a simple symptoms, but yeah, that's it.
I was just going to add, like, yeah, everyone should read Irene and Emmett's meta-analysis / review on the data on this, because I think that's the most up-to-date review that's been done, hasn't it? And there is, at the moment, it's only case report data that has been published, isn't it, on naltrexone?
Yeah, very much. They are not trials. Not at the moment. That would be.
The principle would be first do no harm. So if a patient, I mean, the approach we would take is if there are no contraindications and we think it would be safe, and the patient understands the risks and has capacity, then it is something that perhaps could be tried in the right settings. But I don't think we're anywhere near being able to recommend it as a treatment. Acamprosate's interesting, isn't it? Because I guess we think it might have an effect on glutamate, but I've not used that.
No.
We're not tending to use much relapse prevention medication after detox at the moment, apart from psychosocial support.
Unfortunately, due to the constraint of time, I got a case series of about 20 patients that I prescribed naltrexone, which quite good outcome. But obviously, you need to be explored more in more detail with prospective studies and randomize and in a different way. But yeah, clinically seems to work pretty well with some client.
Okay. Thank you both. And I just wonder whether we could ask Saul one more question. You've been very heroically answering questions in the chat. And I think Ruth asked, could you tell us what support did you have that had the greatest impact?
Yeah, no.
And how could you empower recovery communities to support people with ketamine?
The first thing is, I think I was one of them patients Irene prescribed naltrexone to, and so I can actually say for the craving side of it at the start, it did help. I wasn't waking up and thinking, I want to use. So I can kind of vouch for that. But I think the best support I received is down at Pier Road. They do like a ketamine focused group, which was quite good because with like having anxiety and other people having to like get up to go to the toilet all the time, you kind of feel like you're being a bit of a burden or being disruptive to like to everyone else in the group. So I think having like a group like that where you kind of know that everyone's in the same boat, that it's not really that judgmental, so it's kind of eases the anxiety a bit. I think from there as well, I went to residential rehab for 3 months last year, and that helped a lot as well. It gave me kind of a break to do some work on myself really and try and find out where I was so reliant on using ketamine all the time. I didn't know who I was or what life was like without it. So really just experimenting and seeing what I like to do, what brings me joy and stuff like that has been having that little break to have that eye opener is quite good as well. I think the empowering is, I think the biggest realization for me, like I used to remember, usually days I didn't even want to wake up. Like I'd just pray to God that I didn't wake up, and to realize that life, like there's much more to life than just sitting in my bedroom using, is kind of, that's what gives me joy now. Like as I said, I remember times I didn't want to wake up, and now I set an alarm to wake up because I want to get up and make the most out of the day. So like life can get better.
Thank you, Saul.
That's okay.
Let's move to something much more technical. Do we know if the GI effects, K cramps, etc., are more inflammation driven, or is this thought to be due to receptor activation? And has there been any research into this?
Well, I'd hedge my bets and say it's both, but I don't know.
I don't think it's really very clearly understood, Emily, because when I was looking into it, it doesn't really seem to be very well understood exactly what causes it. But I mean, given the fact that there's a lot of inflammation and it's acting on receptors, it seems like it's likely to be both.
Yeah, especially part polysubstance use as well.
Yeah.
That's the other thing that complicates matters.
A couple of other interesting things. I'm not sure we would know the answer to this, but I think it's an interesting question. Would a history of prior harmful use of other substances render someone unsuitable for treatment of depression with intranasal ketamine? And maybe this is Stephen's question because of his involvement in the trial. And I think there are people on this call who probably know the answer to this question as well.
Well, I can speak to the trial that we're running at the moment for ketamine assisted psychotherapy. So I should stress, when it's not just ketamine on its own, it's ketamine plus rigorous manualized psychotherapy for alcohol use disorder. And we are quite strict that we do rule out people who have had other substance dependencies in order to reduce that risk. Yeah, but I can't speak to depression. I'm not sure.
Okay. Any comments, Irene?
Well, I agree with Stephen, actually. I don't think, I don't have any further comment.
Okay.
Yeah.
Another one, as someone's asked about whether there are any international trends in ketamine use, and I think that's quite an interesting question. And I wonder if anyone's got any thoughts about international trends. Do we know anything about Europe or the US and ketamine?
Well, obviously in Taiwan, Hong Kong is very, very prevalent. And in fact, the vast majority of studies that we have, for example, an A&E population presenting with ketamine addiction, A&E, that's mainly from Hong Kong and Taiwan. They seems to have a very high prevalence, and so in Australia. Thinking about, actually, I was looking at Italy the other day. I'm Italian, so, and actually it doesn't seem there is a particular trend, and it doesn't seem that ketamine is very popular either in Italy or France or Germany. Probably they didn't have the same, but again, they didn't have the same increase in prevalence or increase of recreational use, or simply they don't record the data. Because that is also a great problem in terms of good research paper analysis of epidemiological figures in relation of even recreational use of ketamine. But definitely,
It's just extremely cheap and accessible, isn't it, in the UK at the moment? It's very easy to buy off Snapchat, social media. I was made aware recently that in Liverpool, there are QR codes on certain lampposts that you can scan to be introduced to a ketamine dealer very fast, things like that. People are buying an ounce of ketamine, which is 28 grams, for like £100 or something like that, which is just unbelievable, really.
And finally, just before we close, because Svoboda's prompted me to do it, somebody's commented that are we at risk of giving mixed messages to psychiatric patients? Because on the one hand, we are saying that ketamine is very useful for treating depression. And on the other hand, we're clearly seeing a phenomenon of dependence. And I think maybe this is a question for all of us, really, is how can we manage this substance that offers promise for some people and so much harm for others? And I don't know whether the panel have got any comments to make for that.
Well, I think again, the dose is completely different, and the amount is taken is recreationally and chronic users is astonishingly different. So unfortunately, I think the media is emphasizing a lot with giving the wrong message, especially newspapers and article that that's ketamine is people, they switch from the therapeutic ketamine into misusing ketamine, and there been high profile cases on the news, which obviously is something I don't see in my practice, and talking to other colleagues, we don't see anyone switching from prescribed use of ketamine to misuse. So I think it's mainly how the message is going through the media. and the publicity, the wrong
Thank you.
publicity.
Somebody wants one last comment before we finish on this? I think that's, in which case I think we've finished really. And I'm going to hand over to Deepa and Subodh to finish.
Yeah, thank you so much, Emily. That was indeed a fantastic session, so informative, so much to take in from that session. So thank you, Saul, for joining us today and for sharing your experience and the journey through the recovery. And we really appreciate hearing from you. And thank you to all the speakers. I think, they were all brilliant presentations. So Catherine has kindly put the feedback form link in the chat. So if you can take a few minutes to fill in the feedback form, because we continuously try to improve these sessions based on your feedback. And thanks to Subodh and the RC Psych events team for putting this session together. I think it's been a wonderful session. And thank you for everyone joining in today. And I hope to see many of you in the next Dean's Grand Rounds, which is on the 20th of November. And again, on a very important theme on supporting and educating doctors during investigations. So you take care and have a lovely evening.
Thanks.
Thank you.
Thank you.